I really want to thank Dr. Kendig and also Sarah Burr for a fantastic presentation. At this point in the program, we can now take questions both from our audience here with us at Johns Hopkins as well as those who are watching online. Again, if you are watching online, just click on the link to send us an email question for either of the presenters. We can go ahead and get started if anyone has a question here. Yeah.
Hi, great presentation.
And if you could just wait for the microphone so our colleagues online can hear your question, that would be great. Thanks.
Hi, Carla Alwood from Baltimore City TB Control. A question about ionation rifapentine and HIV positives. Any concern for drug resistance going back to the 2005 MMR where they were looking at rifampin and HIV?
Well, I think there is concern. I remember from the New England Journal article, there was a case of rifamycin resistance, but it was unclear, at least in the article, they said whether or not that was related to the regimen or not. But I do think that that is one of the concerns as we treat more and more patients is, are we going to see rifamycin resistance emerge? And it probably would be a small subset, but you certainly would be concerned about the HIV positive individuals. And I do think that's why it's important, if you have the resources, to really track what's happening to these individuals as they're treated, whether it's in a correctional facility or if it's in local public health.
Okay.
Hi, Lois Eldred from Hopkins Medicine. Sarah, I had a couple of questions about the outbreak investigation. One you may have said already, but what, oftentimes in these low, incidence areas, what's going to happen is they will refer to specialists. What happened at the time that this, index case was referred to a pulmonologist? Did they figure out TB before then, or?
In fact, that inmate didn't get to the pulmonologist, but the CT scan didn't mention TB in the differential, nor did any of these X-rays. And so, and I've got to say from my experience all over the country, repeatedly we're finding pulmonologists and infectious disease specialists that do not know this disease and are giving advice, based on lack of experience, which is problematic.
Right. A second question, you mentioned that it was not feasible to go back to Arizona to contact, to do more, contact investigation, and yet it was, actually early on where he had lost 30 pounds and was so, evidently clinically ill. And I'm wondering if that's just that because there's so much movement through the prisons that you really can't contact and reach her, if it's about expense. Or both.
Yeah, so the question was what happened in Arizona to this inmate, and yes, this case was missed in Arizona, and I didn't mention, but I was in touch with the healthcare providers at that Arizona prison. They went back and looked. This inmate had come to, just like he had in our system, the 30-pound weight loss was documented, the symptoms were present, and they missed it. As I said, unfortunately, most of those inmates had been deported and so were lost to follow-up.
And just to emphasize, that's why the screening and early diagnosis is so critical in this setting, because most of these criminal alien populations, particularly that are with the U.S. Marshals or with ICE, they're very mobile and they're moving. And when the diagnosis is delayed, you really can't extend your contact investigation to that population, and many of them are out of this country.
Okay. We do have a few questions from our online audience, so I'd like to get to those for a minute. There's a question from someone from the CDC in Illinois. It says, both presenters mentioned the importance of obtaining an accurate symptom screen. Many of the patient populations most at risk for TB are also at risk for poor symptom screen, receiving care in understaffed and overburdened settings, English literacy issues, cultural or linguistic misunderstandings between patient and provider. Do you have any suggestions for a symptom screen that would be more effective for these patients? Do you use something that is written at a lower literacy level, or a screening tool more accessible to patients who may have difficulty giving an accurate medical history, or a screen tool that is condensed for busy providers? How do you train and assist busy providers to get an accurate symptom screen given these competing priorities and obstacles?
You raise all the critical questions, and I can say that I don't believe that we've answered them in our setting, and I don't think they've been answered all over the country. Clearly, language appropriate questioning is very, very important, and either with a language line or an interpreter. But this merits further investigation. The questions that need to be asked, which is one of the things that we found in our study, and then how best to ask them. Very important questions.
And I do think it is a charge for public health that we hire more and more Spanish-speaking providers. And certainly we try to do that in the Bureau of Prisons where we have these high-risk foreign-born populations. But I just think in general in public health, just with all the globalization issues, that we need individuals that can speak multiple language in order to communicate with our at-risk populations.
Okay. And this is a very nitty-gritty question. Have you compared the cost of, and I'll try to get this right, INH/rifapentine X3 versus INH X9 MOS in the prison setting?
It's a complicated question. Certainly the drug costs for rifapentine are much greater than for INH alone. But when you consider the amount of staff time it takes to do directly observed therapy for 9 months versus 3 months weekly, 12 interactions, the answer is we have not done the official cost analysis, but my answer to that would be is you really do have to take into consideration the abbreviated time it's going to take to treat a patient. So we think at the end it is going to be cost effective just because we'll have so fewer patient encounters.
And to give you a sense, so for the federal costs, it's about $110 for INH and rifapentine for the drugs, and about $10 for INH.
Okay. We have more questions online, but I think we probably have some in the live audience as well. So.
Hi, my name is Ann Steele. I worked with patients from DOC and BOP over at Bon Secours, and we had some rollout TB cases. And since prevention through screening is such a big concern, my question is, how are people who are screening inmates educated on the importance of that screen? Because what I'm finding is that the communication between, say, a hospital where I worked and the prison system didn't always make it through all the levels that it needed to make through. Sorry, I'm a little under the weather. So my question is, do you do yearly educational sessions on like the frontline people who are screening these patients? Because it could be an issue of not understanding the importance too of the screen.
Yeah, it's a critically important step, and all systems need to be looking at that. And local and state health departments, you play a critical role in getting to know your providers and finding out what is done. Yes.
And I think the amount of training that occurs is going to vary across the country. In the Bureau of Prisons, we are fortunate to have annual mandatory training, not just for our healthcare providers, but for all of our correctional officers. And Sarah has been instrumental in the infection control portion of that training, which is mandatory and covers not just bloodborne pathogens, but TB and influenza. So I would just say, as much as you're able to educate your correctional systems on how they're providing information, particularly, in a lot of the systems, it's not healthcare providers who are even doing the screening. In some of the systems, it's non-healthcare providers. So you really do need to be aware that you may be the training might be very different, obviously, for a non-healthcare provider. And your point is that they really do need to understand why. It isn't everyone's, it's really not a hard sell, right? Because this is an illness that can affect everybody, not just the inmates. It can affect everybody who's breathing the air within a jail or prison. So it's not a hard sell, but you do need to make it.
Yeah, right here.
Hi, Tony Sturgis, Montgomery County Department of Corrections here in Maryland. Given the higher prevalence of HIV in correctional facilities and that there isn't widespread testing, of HIV, and a certain percentage of those that are HIV positive will be anergic. Is there recommendations or are there thoughts about recommendations for routine chest x-rays to be performed, particularly in those states that are considered high prevalence?
I think, again, it gets back to my point of really knowing your patient population. First of all, within the prison setting, we're doing universal HIV testing, and the CDC would endorse that. I will say the seroprevalence for HIV is highly variable across the correctional system. So public health officials do need to be aware of that data because it could drive this decision. But one public health strategy is to do targeted chest x-ray screening of individuals who are known HIV positive. We screen everybody with a chest x-ray that's HIV positive, but to get the test and do the chest x-ray, and again, you could, for foreign-born populations, you could do the chest x-ray screening.
Okay. I'd like to go back to our online questions. Totally agree that there needs to be a collaborative relationship with prisons and jails. Federal agencies such as ICE have picked up prisoners under treatment for active TB disease from our state prisons and whisked them away. Follow-up is impossible because there is no contact person. Treatment is incomplete, and as we know, these people often return to the states, now with potential drug-resistant TB due to interrupted treatment. Where or with whom can state TB control offices interact to locate these persons if they are still in U.S. custody or if treatment has been completed?
That's a common frustration that is being expressed, that inmates are suddenly sort of whisked away in the middle of the night and they're gone, and how do we find them? In fact, there are people to contact. At ICE, there are 2 infection control officers, Diana Schneider and Jennifer Jones. Information on getting in touch with the infection control program there is on their website. Same with the Bureau of Prisons and the United States Marshal Service. One initiative that we sister agencies are looking at is improving the availability of information on contact information. So that's something we hope to make more readily accessible. But in fact, with all of these systems, there are human beings like myself who care, who will respond, will help you find your inmates.
Okay. Great. Yeah, all the way in.
Thank you guys for excellent presentation. Hi, Sarah. But my question relates to information. It kind of hits on some of what you guys have been talking about, but is there a way that information, medical information, screening information collected about an inmate at one facility travels either electronically or in some other way to other facilities and is available to at those other facilities or to other providers?
Dr. Blythe, you ask a difficult question. When inmates are transferred, they generally have what's called an in-transit form. And on that form should be recorded the latest tuberculin skin test result, an x-ray if one was done, any other medical conditions, and any other medications. So that would be with federal inmates. Getting further medical information can often be very difficult, and really the only way is contacting the individual facility and trying to get that information that way.
There's no single electronic record that's used by all.
Yeah, so Dr. Blythe answers, there's no single electronic record. So yes, we do, within the Bureau of Prisons, have a single electronic medical record. So if you have an inmate that went from one federal BOP facility to another, yes, indeed, we have all that information and you can get it. For United States Marshal Service inmates that's contracted with that 1,800 local jails, no, there's no common medical record, and same with ICE.
We do have, the electronic medical record does include a pharmacy record, so we would have all the detailed information about TB dosages. The Healthcare Affordability Act does require, the federal agencies to develop electronic medical records that are interoperable. that's a long-term challenge, but at least we do have legislation that is moving us in that direction. So ultimately, the goal would be that we would have this interoperable data elements that would go from one system to another.
Okay. Okay.
Good afternoon, Mark. New York Women Accepting Responsibility. My question is actually in two parts. What happens if you have a person who's eligible for early parole or early release prior to being diagnosed, and then sometime in that process they're diagnosed and they begin their treatment? Would that treatment follow them out of the system?
Sure. So the question is about referral once a person's diagnosed with TB. And indeed, if someone is in the midst of a diagnostic workup or has been worked up for TB, ideally a referral will be made. We make every effort in our system to do that. And in fact, we work very closely with two international referral agencies, Cure TB and TBNet, to make referrals to other countries. That system breaks down a lot, though, in some of the smaller prisons and jails, I know from personal experience.
We have a couple more questions online. Wondering, as part of the contact investigation, whether the TB authorities in Mexico were contacted?
In general, the CDC, the Mexican health authorities do not do any follow-up except for treatment of active TB disease, or occasionally if there were like a known HIV-infected contact to our MDR-TB case. But the resources in Mexico do not include contact investigation and treatment of latent TB infection. So yes, they will respond, and they do often beautifully with cases that are diagnosed with active TB, but not latent TB infection or contact studies.
Okay. And then this is another question, I guess, for Sarah about the case that was highlighted. Were there any cases identified in the other states where the inmate had been housed? Have any cases among inmates surfaced around the country with similar PFGE patterns?
At this point, no. Although we recently have identified a possible a case at our facility A just this week. It's a possible case that's related. I do suspect that over time, inmates with the same DNA fingerprint will be identified, or former inmates. It just seems extremely likely, but we haven't heard of that yet.